The following podcast is part of a certified educational activity titled Betting on CAR T-Cell Therapy, Expert Perspectives on Effective Integration Strategies and Achieving Improved Outcomes Across Hematologic Cancers, featuring Drs. Michael Bishop from the University of Chicago, Karen Jacobson from the Dana-Farber Cancer Institute in Boston, and Michael Pulseifer from the University of Southern California in Los Angeles. Access the entire activity and complete the post-test at peerview.com/MSF860. Downloadable slides and practice aids are also available.
Good day and hello. Welcome to Betting on CAR T-Cell Therapy, Expert Perspectives on Effective Integration Strategies and Achieving Improved Outcomes Across Hematologic Cancers. I'm Dr. Michael Bishop from the University of Chicago, and today I'm joined by my good colleagues, Dr. Karen Jacobson from the Dana-Farber Cancer Institute in Boston and Dr. Michael Pulseifer from the University of Southern California in Los Angeles. So today's agenda is part of this How I Think, How I Treat sessions, and we'll have 3 talks. One is integrating CAR T-cell therapy into leukemia treatment that will be presented by Dr. Pulseifer, followed by Dr. Jacobson presenting expanding evidence for CAR T-cell therapy in non-Hodgkin's lymphoma, a closer look at diffuse large B-cell lymphoma and mantle cell lymphoma. And then I'm going to close it out by talking about emerging CAR T-cell therapies in CLL and thoughts about future applications. So I hope you'll find this interesting. And with that, I would like to introduce my colleague, Dr. Michael Pulseifer, who will talk about CAR T-cell therapy and leukemia. With that, Michael.
Thank you very much for the opportunity to present today. What I really want to focus on today is taking a chance to really, again, talk about practical treatment of patients with ALL with CD19 targeted CAR T cells. Now, in order to do that, what I'd like to do is first give you a little bit of perspective and the latest data on the tools that we actually have available, things that we can use. So, for example, again, this just gives you perspective. In pediatric ALL, what we see is outstanding outcome for most children. But once patients have relapsed, especially if they've relapsed twice, then their outcomes are very dismal. Now, this has changed tremendously, and you will see as I present a little bit further that all of a sudden this survival of 10% or less is much, much better, greater than 50%, and in some cases 70 to 80%. I'll give a brief introduction to some of the latest data on Kymriah or Tisagin Leclocel, talk to you just a little bit about the Kite product, which is in phase 2 testing, and mention a couple of other types of CARs, some that have been tested from the Hutch and UCART19. Now, many of you are very familiar with the original Eliana trial, which is what led to the first CAR T-cell approval in children. This trial gave standard lymphodepleting chemotherapy with cyclophosphamide and fludarabine and a single dose of a 4-1BB based vector. Now, this is very important to understand that this particular type of vector gave long-term engraftment and was present and has been present in many patients who've been treated with CAR T cells for many, many years. But oftentimes you can lose that vector. And we're going to talk a little bit about that and how important it is to follow it very closely. What this trial did is have a primary outcome of remission, but you had to have the remission tested twice. And so these were patients who weren't in remission just once, but they were in remission for at least a month, once initially, and then a second test 4 weeks later. Now, if patients obtained remission, and 81% of them did, then the duration of remission, you can see listed right here. There's a cluster of early relapses that can occur in the first year, and you see that after that first year, very little relapsing is occurring. And so you have a stable remission that occurs in years 2 and 3. And I'm going to focus on looking carefully at this particular curve and trying to decipher who's potentially going to relapse by some of the methods that I'll review a little bit later. Overall survival was better because many times when patients relapse or have other issues occur, they can be salvaged, and we're going to talk about that as well. Now, this is the real world data, and as I mentioned earlier, in the original study, 81% of patients achieved CR. In this real world study from CIBMTR, what you see is about the same amount of patients attained remission, over 80%. And at 6 months, you can see about 66% event-free survival, with overall survival very high at 87% at 6 months. This next slide shows the duration of the response in the real world study as well. And it seems very comparable with the Eliana trial. Now, I want to talk briefly about Zuma. What happened in this particular trial is this is a CD28 based CAR vector. And the goal, of course, was to take patients relatively quickly through their CAR and get them to transplant. CD28 vectors don't last long, and this is very important in ALL. And transplant is part of this particular therapy. This is results of the early studies, which led to a phase 2 dose that was chosen quite early on of 1 × 10⁶. And right now that study is ongoing. So what I want to do for the 10 minutes that I have remaining in this talk is really talk about how I think about CARs and how I treat, so that you can have a flavor of what we're really doing right now. First question then is, who's a candidate for ALL CAR T-cell therapy? Now, the first 2 things you see here, failed multiple regimens and failed transplant, those are kind of what is well established and FDA approved. And most people would agree that patients who relapse after transplant, especially if they relapse prior to transplant, and have failed multiple regimens, have a very dismal outcome, and they absolutely should be treated with CARs. There are a number of patients, though, that we should be thinking carefully about. Specifically, very high-risk CR1s. This is being studied right now in a trial with the Children's Oncology Group. There are also a lot of proposals that are being put forward about when after first relapse. After first relapse, we're often able to salvage patients with standard chemo followed by transplant. But the question is, should we identify patients that should go to CAR after first relapse? What about patients who really need transplant therapy, but they can't get transplants because they're not eligible? These are a number of patients who are really being considered carefully. Now, I want to make an important point right here. And this is something that, again, isn't necessarily evidence-backed, but it's really an important part of how I treat. And there's a lot of indirect evidence that suggests that it's important. That is when you should collect. I always encourage very much patients who are referring, or doctors who are referring patients to me, to make sure that they collect very early. Many insurances now are approving collections upfront quite quickly. My mantra is to avoid chemotherapy if possible. So if someone is relapsing after transplant and you detect a hint of it, get them referred to a CAR center, or if you're doing CARs at your own center, I would recommend you collect them as early as you can to avoid causing T-cell exhaustion and potentially harming T-cells. Next, let's talk a little bit about some of the other issues that I want to address. Current management questions I'd like to get at very briefly in this talk is do we need to manage CRS and ICANS very aggressively? And I'll talk briefly about that. Next, I want to cover when do we need a transplant after CAR T-cell therapy in ALL? Finally, if you don't choose a transplant after CARs, can you predict or potentially prevent relapse? I'll then talk about what you do when patients potentially relapse, or when you should infuse them if you've lost B-cell aplasia. Now, the larger questions that I would love to get into, we simply don't have time to talk about today, and that is, can we move the CARs earlier into therapy? Can we improve T-cell persistence? And can we decrease antigen escape without destroying persistence? So let's talk about these practical questions and really how I treat this. So CRS, our older approach was hypotension on significant pressors. You couldn't even have 5 to 7 of dopamine. You really needed to be on high dose pressors in order to get treatment. You had to have significant respiratory compromise or rapid worsening. But the newer approach that has been shown to actually work very nicely is to treat patients a little bit earlier. For persistent unresponsive fever, patients who are on any oxygen and any hypotension at all, this is when most individuals are now treating. And I find that treating patients this early leads to much better response. And there's good evidence that has been put forward by a number of investigators stating that it doesn't hurt initial response. There's not a lot of data about long-term response, but it doesn't hurt initial response. As far as fluid management, I always tell people to be careful about over-bolusing. It's better to give patients pressors than bolusing them too much because you don't want them to get intubated. Once you treat with tocilizumab, if they're not improving within 12 hours, add steroids. And you can add either Solu-Medrol or Decadron, and then additional doses of tocilizumab or other meds. Once, however, you have CRS under control, I think a key thing to keep in mind is to wean steroids relatively quickly. How about ICANS? Now, ICANS is a real challenge. And the reason for this is that initially in the Eliana trial and other trials, we didn't really treat ICANS. With tissential neclocell, at least, there hasn't been a real good signal for diffuse cerebral edema. However, with a number of other trials, CAR T cells has led to significant edema and swelling, and it has made everyone in the field very worried about the possibility of this. So there's a lot of variation in this. What I tend to do is wait until at least grade 3 ICANS. And if it's significant and potentially worrisome, I will consider imaging. I will often give steroids. I usually start with dexamethasone. There are other things to give, other causes to look for. But once we get good control of ICANS, then I'll wean rapidly as well. Let me tell you a little bit about how I approach the question of transplant at CHLA. This is an important one because there's been reasonable data put forward by Chinese groups and by the Seattle group that's being published very soon that transplant after even 4-1BB based CARs can be beneficial. However, many of our patients don't want to have transplant and they'll avoid it if they can. So I tend to think of it this way. If a patient has never had a transplant and they're a candidate for myeloablative transplantation, what I will do is offer them either a CD28 or a 4-1BB based or UCART up front, because we know that we have an excellent chance of getting them into a very deep remission, and then do a transplant from a donor. If, however, they have had a previous transplant, or they're a poor transplant candidate, or the family simply does not want to do transplant, and they take the risk of a 50-50 chance of relapsing, what I'll then do is plan for a 4-1BB based approach that's been proven to have persistence. And right now, certainly Kymriah has been proven to have persistence. The Seattle approaches have been proven to have persistence. But I'll give them that particular treatment, and then I'll follow for vector loss or loss of B-cell aplasia. Now, B-cell aplasia has been assessed in many different ways. I prefer looking at numbers of cells, so less than 50 per microliter of CD20 positive cells is generally what I've done. Although I've had a few patients hanging just above 50 and stable, when they're rising very consistently and headed toward 100, 200, et cetera, then you know they've lost B-cell aplasia. If they lose B-cell aplasia relatively early, then I'll consider reinfusion, and I'm going to talk a little bit more about reinfusion. Our weakness with this approach, however, is that CD19 relapse occurs. And when it occurs, you can't really prevent it with this approach. And patients become very fatigued. I find that it's difficult to get them through multiple therapies. Sometimes after one or two therapies, they'll really be disheartened and they'll want to give up. This is a look at B-cell aplasia. And what you can see is the majority of patients treated with Tisagen Leqvio at last have significantly prolonged B-cell aplasia. B-cell aplasia doesn't guarantee that you won't relapse, but what it does is it at least gets you on the playing field where you may not need to have a transplant. Here's what happens, though, when you have prolonged B-cell aplasia. And this is some data that I'm presenting from my own institution. If by 9 months you still have B-cell aplasia, here's your event-free survival at my institution. If by 9 months you've lost your B-cell aplasia, here's what occurs. Now, you might be able to move this up to about 6 months. You really need at least 6 months of B-cell aplasia to be able to get on this. You have a very good chance of cure curve. This is more data adding something that we miss when we lose a tool of assessing for CD19 negative relapses, and that is looking with NGS. This is some data, and more data is going to be published with this very soon, showing that if you have NGS positivity early on, any detectable NGS positivity, then there's a very high risk of relapse. And so this, combining NGS and measuring it early on at perhaps month 1, month 3, et cetera, this really helps with trying to define who should potentially go to transplant and who doesn't necessarily need to go to transplant. So I think in the near future, we're trying to work out better ways of defining who should and should not go to BMT. And I think a combination of NGS, MRD assessment, and persistence of B-cell aplasia will help us make that determination. There's a current study underway that is looking carefully at CAR T-cell reinfusion and whether that can overcome loss of B-cell aplasia, and many centers are participating in this. We hopefully will have a lot more experience with CAR T-cell reinfusions, but here's how I look at it. If patients have lost B-cell aplasia less than 6 months, they have a good donor, NGS, MRD negative remission, it's reasonable to take them to transplant because you're going to have a very high chance of curing them. If they are a poor candidate and the study is open, it's why not? Give them an infusion. It's worth a try, and I generally give my infusions together with pembrolizumab. If they lose B-cell aplasia a little bit later, between 6 to 12 months, I certainly consider reinfusing them because more B-cell aplasia likely will lead to more cure. If B-cell aplasia loss occurs after 12 months, I wait because many of those patients are already cured. And if they relapse, they have a very high chance of being salvaged with a single reinfusion of CARs. How about managing relapse? Now, often my patients have not had a transplant when they go through the CAR T-cell process. And what I then do is I go full bore, trying to get them back into remission and attempting a transplant. If they're CD19 positive, there's a couple of ways of doing that. You can give them a humanized or fully human CAR, put them on other research CARs, give them reinfusion if it's a late relapse, or even chemo followed by other things such as blinatumomab. Once you get them into relapse, though, after they've relapsed with CAR once, it's probably wise to take them to transplant at that point in order to salvage them appropriately. CD19 negative relapses, I either put them on experimental CD22 CARs or other CAR T protocols, or treat them with inotuzumab, and then I get them to transplant. This is my institutional data. What you can see here is that CD19 positive relapses, we can salvage at a little bit better rate than CD19 negative relapses. But we definitely can relapse patients we can salvage patients who relapse after CAR T therapy. And I want to turn the time back over to Mike.
Well, thank you, Michael, for that great presentation and covering a lot of topics that we're all very excited about and wanting to know what the right answer is, and in particularly how it's going to apply to adult ALL. So, and relative to that, it kind of makes a nice transition to Karen Jacobson's presentation, because she's going to talk about the use of CAR T cells for non-Hodgkin's lymphoma, and the biology of non-Hodgkin's lymphoma, the efficacy, the toxicities, and more importantly, the management and the biology behind relapse is a markedly different than what we have observed in ALL. And so with that, Karen, I'm going to turn it over to you, and I'm excited to hear your talk.
Great, thanks so much. And so we'll switch gears a little bit and talk about expanding evidence for CAR T-cell therapy in non-Hodgkin lymphoma. We'll start with a discussion of diffuse large B-cell lymphoma. So when we're thinking about CAR T-cell therapy for diffuse large B-cell lymphoma, obviously we need to identify patients who are eligible. And so right now this applies to patients with large cell lymphoma who have relapsed after at least 2 lines of therapy. There are some groups of patients that we may want to think twice about, and those are patients with active infection or inflammatory disorders, which could obviously get worse or worsen toxicity after CAR T-cell therapy. But in general, we're looking at a therapy in the 3rd line for these patients. It's important to know that what a patient will undergo when they get referred to a specialized expert center for therapy. It will be for a period of intensive therapy, which will start with obviously for leukapheresis for collection of CAR T cells. And when the cells are manufactured and returned to the center, patients will undergo lymphodepletion prior to CAR T cell infusion. And then after their CAR T cell infusion, they're going to be watched very closely for some toxicities that we'll talk about later in this talk. And those toxicities will be managed, and we'll talk a little in more detail about that later in this talk. And then finally, after they sort of get out of that acute toxicity window, they're going to be monitored for longer-term follow-up for relapse or recurrence. We do have issues with ongoing B-cell aplasia as well, although it seems to be less important for long-term remissions than B-ALL, which you just heard about. And then there are some issues with long-term cytopenias in these patients, and patients need to be monitored for that. There were 3 pivotal studies that led to the approval of 2 different CAR T-cell products for adults with diffuse large B-cell lymphoma, and a 3rd study that's being reviewed by the FDA currently, and we expect approval imminently. The Zuma2 study looked at axicabtagene ciloleucel, or Yescarta, from Kite. The Juliette study looked at tisagenlecleucel, which we just heard about, or Kymriah from Novartis, and the Transcend study is looking at lisocabtagene maraleucel, and this is from now BMS. They all looked at slightly different doses of their CAR T cells, and mostly these were given to chemotherapy refractory patients, although the requirement for patients to be refractory differed from trial to trial. A good proportion of patients had relapsed after an autologous stem cell transplant. The studies differed with respect to whether they allowed bridging therapy. Really, the Juliette and the Transcend study did allow bridging therapy between leukapheresis and CAR T-cell infusion, whereas the Zuma2 study did not. You can see that 91% of patients on Zuma2 were treated after apheresis, compared to 76 and 85% on the Juliette and Transcend study. And that's owing to the fact that the turnaround time for axicabtagene ciloleucel is actually only 17 days, which facilitated not needing bridging therapy on that study. And as you can see, as I mentioned before, the Zuma2 and Juliette study led to FDA approval, and the Transcend study is currently under review. So we'll take a little bit of a closer look at the 3 different studies. So for the Zuma2 study, these are patients with relapse refractory large cell lymphoma. The median follow-up has been much longer now, but at the time of this reporting was 27 months. And you can see that 83% of patients responded and 58% of patients had a complete response. We'll take a little bit of a closer look at the duration of response, PFS, and overall survival curves in the next slides. So when we look at progression-free survival, just like we saw in ALL, patients who achieve a complete response have a much better progression-free survival than patients who have less than a complete response or stable disease, and that's depicted here. Their median progression-free survival has not been reached. When we look at overall survival, we recently updated this at ASH, and this is now with 51.1 month follow-up, and you can see that about 40% of patients are maintaining, or 44% of patients maintain or are alive at 4 years of follow-up, and there seems to be very little tail drop-off on the tail of this curve. When we look at the Juliette study in terms of progression-free survival and overall survival with Cytokine Lyklusil, you can see very similar curves here. Again, patients, the theme here is that patients who achieve a complete response have a much better PFS and OS than patients who do not. And you can see that with longer term follow-up as well. So now we have longer follow-up, now 24 and 36 month PFS, which is 33 and 31% for all patients respectively on the purple curve. But you can see that amongst responders, 60% maintain their response at 24 and 36 months of follow-up. And then finally, we'll look at the Transcend study, which had similarly high overall response rates and complete response rates at 73 and 53%, and similarly good duration of response and progression-free survival curves. Again, patients who achieve a CR have better outcomes than patients who don't. And the theme for all of these studies is that about 40% of patients are alive and without evidence of relapse with multiple year follow-up. Most of the relapses, just like in ALL, happen within the first 3 to 6 months of follow-up. And usually if somebody reaches 6 to 12 months of follow-up without having relapsed, we expect that those patients have a high likelihood of being cured of their lymphoma. Now, because it's been so successful in the third line, the obvious question is what happens if we move it up a line of therapy into the second line, where standard of care right now is salvage chemotherapy with an auto transplant for those who have chemosensitive disease. And there are 3 randomized trials, the Belinda study, the Zuma2 study, and the Transform study, that are looking at each of these products in the second line compared to standard of care. All of them have the same primary endpoint of event-free survival, and we are awaiting the results of these studies. They're right now all done in patients with high-risk relapsing diffuse large B-cell lymphoma, which is defined as either primary refractory disease to their upfront chemoimmunotherapy regimen or patients who relapse within 1 year of their upfront chemoimmunotherapy regimen. So we'll keep our eyes out for those results. So when I think about my take-home points for CAR T-cell therapy and large cell lymphoma, clearly this is transformative for patients with chemotherapy refractory disease who generally had survivals on the order of about 6 months with other available therapies. Now 40% of people are alive and without disease relapse multiple years after a single infusion of an anti-CD19 CAR T-cell therapy. And so presumably we think these patients are probably cured. We've now seen several real-world studies using these anti-CD19 CAR T cells and seen similar rates of response and toxicity in a broader population of patients, including patients that would not have been eligible for these clinical trials, which is incredibly encouraging. Some caveats to the studies are that patients with comorbidities do appear to do a little bit worse, but they still do better than other available treatment options. And so treating centers now adapt their eligibility criteria according to what they feel is safe and appropriate. And I just might ask Dr. Bishop at this point, do you have any, how have you expanded your eligibility criteria for CAR T given some of the results of the real world studies?
So Karen, that's a great question. So we will take patients with more compromised performance status and maybe increased comorbidities, but we are aware with those patients that they're probably going to have a worse outcome. But I agree with you completely that the options for these patients are so limited that it's worthwhile to at least try that in this patient population. And we've seen this similar success as what you reported before.
Great, and it's a perfect lead into this case that I wanted to share with everybody. This goes along with who should we consider for CAR T-cell therapies. So this was a patient that I treated up in Boston. He's a 68-year-old man, and he had a triple hit diffuse large B-cell lymphoma who was treated with 3 cycles of R-EPOCH and had clinical and radiographic progression after cycle 3. He went on to receive 1 cycle of our DHAP and did not respond. And then he came to see me, and we collected his CAR T cells. In between collection of his CAR T cells and actually bridging him with polatuzumab, he actually developed Fournier's gangrene and had to have a massive surgery with extensive rehab, which led to the absolute need to bridge him with something like polatuzumab. And this was his PET scan going into CAR T cell therapy. Clearly, his performance status was not a 0 or 1. He clearly had just recovered from an extensive infection. Obviously, you can see from the response PET scan that he ran into trouble with obstruction of his kidneys and needed bilateral percutaneous nephrostomy tubes. But 1 month after CAR T cell therapy, he was in a very good partial response. And I just got word from his local oncologist that now 9 months later, he's in a continued complete metabolic response. So this is certainly not someone you would have taken on the clinical trials, but this is the power of what CAR T cell therapies can do. And it certainly gave this 68-year-old gentleman a shot. So I think that we've learned that we can expand eligibility, see excellent outcomes, and maintain the safety profile we saw on the clinical trials. Speaking of some of those toxicities, obviously we focus on cytokine release syndrome and ICANS, and here are just some of the symptoms you can see with cytokine release syndrome and some of the symptoms you can see as part of ICANS. And the typical timing with diffuse large B-cell lymphoma is that cytokine release syndrome will start somewhere between 2 and 4 days after infusion and last for about 3 to 5 days. And then neurologic toxicity usually lags a couple of days later. It will usually start around the time shortly after the peak of cytokine release syndrome, sometime around day 5 to 7. And the durability of neurologic events is a little bit more variable, but can last anywhere from about 5 to 10 days, and before patients have a recovery. So depending on whether patients develop cytokine release syndrome and neurologic events, this acute risk period can be anywhere from 7 to 28 days. And patients obviously need to be monitored closely during this time for delayed onset of either of these toxicities. When we look at the rates of cytokine release syndrome and neurologic toxicity in the 3 pivotal trials, you can see that there is a differential rate of side effects with the Zuma2 study using a CD28 CAR and the Juliette and Transcend studies using a 4-1BB CAR, where rates of grade 3 and higher cytokine release syndrome and neurologic toxicity seem to be greater with the CD28 CAR on Zuma2 compared to the 4-1BB CARs on Juliette and Transcend, with the caveat that the Juliette study used a different grading system for cytokine release syndrome, which is not translatable to the Lee grading system that was used on Zuma2 and Transcend. When I think about how I treat CRS in the current era, one thing that we've learned in lymphoma, just as we discussed in BALL, is that treating patients a little bit earlier is actually can actually prevent them from getting sicker and does not seem to impact efficacy overall. So when we think about the grading for CRS that's listed on this slide is according to the Lee criteria, but I should note that it's we now have a consensus grading system offered by the ASTCT that is really supplanting the Lee grading criteria for future studies, but these are the criteria that were used on these clinical trials, so they're included here. And you can see that we even are employing therapies for persistent grade 1 CRS, and when patients get any hypotension or hypoxia, we start to treat patients with tocilizumab with or without dexamethasone. And then obviously when patients develop grade 3 or higher CRS, which is the grade of CRS that requires ICU level care, we are employing tocilizumab and dexamethasone with or without high-dose steroids if they are ultimately refractory and progress to grade 4 CRS. When we think about neurologic toxicity, what's shown here are the grading system according to CTCAE, which was used by the pivotal studies, but has also been updated with the consensus ASTCT guidelines for future studies. But similarly, we see that patients with early grade or low grade neurologic toxicity can be observed, but patients with grade 2 or higher neurologic toxicity may warrant treatment with dexamethasone, especially if their neurologic toxicity has occurred early after their CAR T-cell infusion, as those patients tend to have a more rapid trajectory. And then for patients with grade 4 or life-threatening neurologic toxicity, high-dose Cell-004 is in order. And so I'll switch gears and talk about the new data related to mantle cell lymphoma, which, unlike diffuse large B-cell lymphoma, is really considered an incurable non-Hodgkin lymphoma outside of allogeneic stem cell transplant. Previously we treated these patients with chemotherapy, with or without high-dose chemotherapy and an autologous stem cell transplant, and then for relapsing patients, BTK inhibitors. But once patients relapsed after BTK inhibitors, their overall survival was very, very short, on the order of months. And so that is where CAR T cells have been tested. And so CAR T cells are appropriate for patients with mantle cell lymphoma that are relapsing, like I said, after chemoimmunotherapy and a BTKI. We do recommend that patients continue their BTKI really up until their next therapy or CAR T cell therapy to avoid disease flare that could potentially lead to patients becoming too sick to get their CAR T cells. And again, the caveat that patients with active infection or inflammatory disorders need to be considered closely for whether they should be receiving CAR T cells in general. The same referral and practice guidelines apply for mantle cell lymphoma. Patients get referred, they have their cells collected, they undergo lymphodepletion, they have their period of acute toxicity observation and management after their CAR T cell infusion, and then they enter longer-term follow-up monitoring for relapse and recurrence, issues related to B-cell aplasia, and issues related to long-term cytopenias. So the recent approval of brexacaptogene autoleucel in relapse refractory mantle cell lymphoma was notable. This is an anti-CD19 CAR T cell therapy with a CD28 costimulatory domain that is actually very, very similar to axicaptogene ciloleucel, except that there's an extra step in manufacturing that removes circulating CD19 expressing malignant cells. It's the same product that was used in the Zuma2 study that you heard about in adult B-ALL earlier. And it was approved based on the results of the Zuma2 trial, which we'll go into some detail about in the next couple of slides. And then I'll also present some phase 1 evidence of lisocabtagene maraleucel in relapse refractory mantle cell lymphoma. So the Zuma2 trial was very similar to the Zuma1 trial that we talked about earlier. Patients were enrolled at leukapheresis. They were allowed to have bridging therapy with either steroids or continuation of a BTKI, like ibrutinib or acalabrutinib. They then underwent their lymphodepletion, they got their CAR T cells, and they entered their follow-up. The primary endpoint of this study was objective response rate by independent radiology review committee assessment. So the results of the Zuma2 study have been published, and you can see that the overall response rate was 92%, and the CR rate was 67%. And we saw an update to this at ASH in December, where at a median follow-up of 17.5 months, 29 out of 60 patients, so 48% of patients, were in ongoing response, and 70% of patients who had achieved a CR were in ongoing response. So the same themes that we see in diffuse large B-cell lymphoma. And here are the duration of response, progression-free survival, and overall survival curves. So, we're really, I think, with longer follow-up in this disease, we're really interested to see if this is actually transformative in terms of changing the natural history and making an incurable disease potentially curable with cellular therapy. And so we await longer follow-up for this study. At ASH this year, we also saw the results of a cohort of patients with mantle cell lymphoma treated on the Transcend NHL-001 study with lisocabtagene maraleucel, where we saw this was 32 patients, and we saw similarly excellent response rates at 84% and complete response rates at 66%. The follow-up was short, only 5.9 months, and so we await longer follow-up for this study, just as we do for the Zuma2 study. On both studies, it's important to note that the responses and the duration of response really is very similar amongst all risk groups with mantle cell lymphoma, including patients with high Ki67s, with blastoid morphology, and with TP53 mutations. Safety for the Zuma2 study actually is very similar to what we see in large cell lymphoma on the Zuma1 study, with grade 3 or higher cytokine release syndrome occurring in 15% of patients and grade 3 or higher ICANS occurring in 31% of patients. There were some cytopenias as well as infections, and there were 2 grade 5 infections on this study. And just like we saw in large cell lymphoma, lisocabtagene maraleucel seems to have a more favorable safety profile with lower rates of grade 3 and higher cytokine release syndrome, as well as grade 3 and higher neurologic toxicity compared with the CD28 CAR used on the Zuma2 study. So when I'm thinking about CAR T cells and mantle cell lymphoma, I think it's important to note we have an FDA-approved product for mantle cell lymphoma, which really establishes a standard of care when one didn't exist before. We've seen some promising early phase evidence with lisocabtagene maraleucel, and it's just important to note that prognosis after BTKI relapse is typically very poor, and the use of CAR T cells in this context is practice-changing for patients with high-risk disease. When I want to think about how to use CAR T cell therapy in mantle cell lymphoma, when you think about selecting a patient, I think it's important to note that the FDA was actually very forward-thinking and thinking about the label for Brexucel. So whereas the clinical trials that I talked about today all included patients who had relapsed after chemoimmunotherapy, as well as a BTKI inhibitor, the FDA approved Brexucel for mantle cell lymphoma regardless of prior exposure to BTKI inhibitor. It's for any relapsed or refractory mantle cell lymphoma. And that's because the landscape for the treatment of frontline mantle cell lymphoma is changing and may be a combination of chemoimmunotherapy and a BTKI inhibitor in the future. And so, or maybe a BTKI inhibitor alone for some high-risk groups. And so that allows investigators and treating clinicians to decide who should get CAR T cells in the second or third line, as opposed to diffuse large B-cell lymphoma, where currently it's only approved in the third line. And I think that the other thing to note is that toxicity seems to be very similar to what we see with diffuse large B-cell lymphoma. And so all of the practice guidelines we have for treating cytokine release syndrome and neurologic toxicity with axi-cell or the other CAR T cells in diffuse large B-cell lymphoma can be applied to Brexucel in mantle cell lymphoma. I want to end with one word on the future of CAR T cells in another type of non-Hodgkin lymphoma, also incurable, the indolent non-Hodgkin lymphomas, including follicular lymphoma and marginal zone lymphoma. We saw results from Zuma5 presented at ASH this year, looking at axi-cell in this group of patients, as they're all in the third line and beyond, with very, very high response rates at 92%, and complete responses seen in 76% of patients. At a median follow-up of 17.5 months, 64% of patients with follicular lymphoma were still in response. And of the patients who achieved a CR, 78% of patients maintained their response. And we saw early results from the Novartis study looking at tisagenlecleucel in relapsed refractory follicular lymphoma. This is from the Elara study, where the overall response rate was similarly high at 83% with a CR rate of 65%, and with 9.9 months median follow-up. Both the duration of response and progression-free survival have not been reached. So again, with longer follow-up, we hope to see that just like in mantle cell lymphoma, maybe this will be really, really practice-changing and disease natural history transformative. So with that, I will turn it back over to Dr. Bishop.
All right. Thank you, Karen, for that great presentation and very exciting data relative to the expanding use of CAR T cells in non-Hodgkin's lymphoma. It's my pleasure to close out what I think has been a great session. I'm the tail end of this, and following Michael and Karen, this is going to be a very tough act to follow, but I'm going to present on the emerging CAR T cell therapies in chronic lymphocytic leukemia and thoughts on future applications. And this is kind of like a back to the future presentation, because for our younger members of the audience or don't follow the history of CAR T cell therapy, which is really a kind of a short history, the first successful application of CAR T cells in hematologic malignancies was in chronic lymphocytic leukemia and you would have thought that this would have been a broader use, but we have outstanding agents in the treatment of chronic lymphocytic leukemia. And despite the very early successes with this, we also found that CLL presents its own challenges in regard to CAR T cell therapy. So, but we've seen some recent data. And matter of fact, in 2019 at ASH, we saw the initial results of the Transcend Cll-004 study. And for those of you who are unfamiliar with this trial, it uses a CD 4-1BB CAR construct and has equal numbers as in the other Transcend studies, it used equal numbers of CD4s and CD8 cells and in the manufacturing process. And so in this, to be eligible, patients had to have relapsed or refractory CLL or SLL. They had to have failed or been ineligible for a BTKI inhibitor. And then they defined this as for patients who had high-risk disease, such as 17p deletions, they had to have at least 2 lines of therapy. And for standard risk disease, at least 3 lines of therapies. And just for those who are just interested in the majority of these patients, 85 to 90% had either failed to respond or had progressed on a BTKI. And so the primary endpoint was a dose-limiting toxicity because this was a part of a phase 1 study. They got standard lymphodepletion with fludarabine and cyclophosphamide. Then they would receive the lysocell product 2 to 7 days after conditioning and then longer-term follow-up. And so at that time, there were 2 doses being studied. The first was at a level of 50 million CAR T cells and then was advanced to 100 million CAR T cells. So we heard the initial exciting results of that in 2019, and we saw that many of these patients did have significant response, not much at a lower dose, but we have an overall response rate of 82%, including 46% CRs with incomplete hematologic recovery, 36% PRs, 27% of patients, which you can see from the swimmer's plot to the left, had a deepening ongoing response, and responses were durable, with 50% of patients who were in response, and only 2 of these responders progressed beyond 12 months. And 4 of the 15 patients received unmeasurable minimal residual disease response have progressed. So showing that, and very interesting about this, and what they do with the biology, they saw that in the progression that these 3 of those 4 relapses were Richter's transformation. And it's important to know that Richter's transformation was actually ineligible for participation on Transcend 004. So at this year's ASH, we got updates on this, and so we have longer-term follow-up. And what you're seeing here is probability of durable responses in a larger cohort. And you can see that we have at 12 months, we have a 55% durable response. And if we look at probability of progression-free survival, and again, we look at 12 months, we're right around 55%. So it does appear that this has similar results of what we've seen in diffuse large B-cell lymphoma, and we're hopefully going to see with longer-term follow-up a tail on the curve. So in terms of toxicities related to this, they actually did look relative to whether or not the patients received monotherapy, and there was a subgroup what they looked at who had BTKI inhibitor and included venetoclax, because that's always a big question relative to this patient population, as venetoclax has been added to the armamentarium in the treatment of relapsed and even upfront use in high-risk CLL. And so when we look at toxicities, and again, coming back to an important point Karen made, is that these are using older criteria, not using the current ASTCT, but we see grade 3 and grade 4. We see that the toxicities between the 2 groups are relatively similar. When we look at CRS, 74% versus 64%. When we look at grade 3, 9% versus 18%. And then when we look at neurologic toxicities, relatively similar, 39% versus 46%, and grade 3 neurotoxicity, 22 versus 27%. And with looking at relative to the management of CRS or neurologic toxicities, 26% of patients received toci alone, 9% in the venetoclax group. Corticosteroids only 4% versus 9%, and tocilizumab in combination with corticosteroids 35 versus 36%. So we can see that there's very similar in terms of these patient outcomes, and again, concern when you're using more aggressive therapy with venetoclax. So the take-home points that I think that are important relative to Transcend Cll-004 is overall response rate of 82%, 45% CRs, and 60% of patients reporting to be MRD negative. There are continuing responses were observed in nearly 80% of patients after achieving CR at 9 months. The phase 2 portion of the study is continuing to accrue patients and is using that 100 million cell CAR dose, as that was found to be slightly better in terms of efficacy and no increase in toxicity. But I think an important portion of this that what I have great interest in is that, and I had mentioned this before, there is a difference in the biology of CLL in general, but if you look at the T cell function from those patients, T cell function we know in newly diagnosed CLL patients is different, and that after treatment it can be different. And matter of fact, investigators from the University of Pennsylvania actually looked at CAR T cells in patients responding to treatment, and they found that in those patients they were enriched in memory-related genes, including IL-6 STAT3 signatures, whereas T cells from non-responders had upregulated programs for effector differentiation, glycolysis, exhaustion, and apoptosis. So again, they were able to differentiate this relative to maybe even predicting who would be a responder and who would not be a responder. But the more interesting, and again, investigators in combination with investigate at University of Pennsylvania, Ohio State University, and at Mass General, they actually looked at function relative to whether or not patients actually had received ibrutinib. So we do worry about that prior therapy may inhibit function, but they actually found that ibrutinib may enhance T cell function. And so this led actually to a subset of Transcend Cll-004 to the addition of ibrutinib along with lysocell. And so when we look here in terms of response, we have patients, all patients. There were 19 of these patients. This is just reported also at ASH, and we had at dose level 1, which is a 50 million, again with adding ibrutinib, and dose level 2 is 100 million. We see 50% at dose level 1 and 67% CRs at dose level 2. And if we look at the degree, we're looking for minimal residual disease in all patients, 89% in the blood, 79% in the marrow, but again, a slightly higher degree of MRD negativity in the higher dose group. So no patient had progressive disease during the first month on lysocell, and only one patient at dose level 1 had stable disease 6 months but later progressed. So these are really exciting results. And again, thinking about the use of combination therapy. Relative to safety, the combination of lysocell and ibrutinib was well tolerated. There was no grade 5 AEs. And when we look at the treatment associated adverse events, anemia in 4, neutropenia in 4. There was atrial fibrillation. Again, thinking about the use of ibrutinib, we've known this is a known complication with this medication. There was hypertension, which also can be seen in infections. So again, these seem to be relatively well tolerated, but it does appear that this combination of ibrutinib with a CAR T cell can be well tolerated. Now, A similar study was also carried out by the Fred Hutchinson Cancer Research Center, which was just published this year in Blood. And it's a little bit hard to differentiate, but they looked at two populations that were extremely well matched relative to their CD19 CAR that they produced at the Hutch, and they did it with concurrent ibrutinib and not. And what you can't really distinguish here, because the slide doesn't, but this upper portion here showed that those patients who did receive concurrent ibrutinib had better expansion in both CD8, and they're showing the CD8 CAR T cells there, as well as in CD4 cells, as compared to this lower blue line here, which formed the median expansion for those who did not receive ibrutinib. So they're actually showing that they can have an effect upon expansion of both CD4s and CD8s with the concurrent administration of ibrutinib. And here is looking at CRS. There appeared to be maybe slightly less toxicity in terms of higher degree of toxicity with concurrent ibrutinib, and it had been suggested in prior studies that ibrutinib actually may downregulate many of the cytokines associated with that, but there was no loss in efficacy. And when they looked at this relative to overall responses, you can see that these responses could be highly durable by looking by response by day 28, and also by doing minimal residual disease by IGH sequencing. So I think this is given two studies which show the potential for combination therapy with CAR T cells. So relative to that, and CLL thinking about using CAR T cells in the future, who should be considered for this? I think these initial results are highly encouraging, but we really do need to see the completion of the clinical trials. And for those patients, I actually think that it really doesn't necessarily need to be 3 lines of therapy. If a patient has had prior BTKI treatment, I think and has experienced relapse even in lower risk disease, I would think those are great candidates for clinical trial and for participation for specifically for CAR T cell therapy. And I am very highly encouraged about using not only BTKI inhibitors to improve T cell function, but the other molecules, and that the biology of CSL is very unique relative to that. And again, these prior therapies can have significant effects upon CAR T cell therapy, both in terms of efficacy and also potentially in decreasing toxicity. And I think that pretreatment strategies may be key. So in the Seattle regimen, they actually, based upon data from Ohio State University, just gave 2 weeks of a BTK and the ibrutinib ahead of the apheresis. And again, we can think about how that might be a great bridging strategy for our patients. And so the other thing is that there are other CLL treatments which may enhance CAR T cell function, and how I can see is that these all be incorporated together into an overall treatment strategy, and may even, what I hope to do is that we may be able to shorten the duration of CLL treatment. So currently, if you start on a BTKI inhibitor, you stay on it until progression of disease, and these medications are not benign. They can have a lot of side effects, and maybe through the incorporation of CAR T cell therapy, we may be able to shorten the duration of the patients being needed on treatment. So with that, I'm going to close what I hope you found to be a highly enjoyable and educational session. I want to thank my colleagues, Karen and Michael. You did a great job. It was really enjoyable. I learned a lot every time that I get to listen to your presentations. And with that, we're going to close the session, and thank you all for participating.
This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MSF860. This activity is supported by educational grants from Kite, a Gilead company, and Novartis Pharmaceuticals Corporation.